Hi everyone, this is Ben Sturbell with Dr. J. Hartley, coming at you from Hartley Chiropractic and Scoliosis Center in St. Augustine, Florida. We're here today to talk to you a little bit about scoliosis. I've been working with Dr. J for the past year and have been diagnosed with scoliosis. So Dr. J, what exactly is scoliosis?
Scoliosis is a 10-degree or more curve from the front view of the spine. So if we're looking at somebody from the front, the vertebrae are tipped 10 degrees or more, and then that creates an angle called a Cobb angle. And if that angle is 10 degrees or higher, it's considered a scoliosis. And there also is a rotational component. So on the x-ray, the vertebrae are actually rotated counter to each other.
Okay. And so here at your clinic, you treat scoliosis, correct?
Yes, so we specialize in scoliosis. We're a clear certified scoliosis office, so I went through a special certification, had to shadow other clear doctors, had to do case studies where we reduced 30-degree curve 30% or more. We had to present 4 of those case studies to the clear nonprofit scoliosis board. And there's other testing and things, but there's a long process of being certified.
Okay. Could you tell me a little bit about your method of treatment here at the clinic? What type of patients come in to get treatment? What are the methods that are used?
So we have 2 main type of patients. We have the scoliosis patient as an adolescent, where the child is diagnosed with scoliosis, usually by their chiropractor, pediatrician, or a school screening, and they don't really have any symptoms, but the concern really is we have this growing scoliosis, and we want to find out what can be done about it preventatively before surgery. And so we have a process called mix, fix, and set, and it's a warming up of the spine, a specific adjustment, and then corrective exercises and traction to get the spine to hold into place. And it's about a 2-hour visit, and so it's an exercise-based combination of chiropractic and traction to correct the spine. So those are the adolescent patients. Then in adult patients, they tend to have more pain, and their concern really is they have a scoliosis that might be getting worse, but usually they're not trying to avoid surgery necessarily, meaning when you have a child with progressive scoliosis, if the scoliosis is 40 degrees or more, they're going to be referred for surgery. The curves are best managed when they're smaller, pre-puberty, like ages 9 through 12. After 12, it gets more difficult. As an adult, people are realizing they have scoliosis, but they also have pain. So their biggest concern is pain. They want to be feeling better.
Okay. So from what I understand, there are different stages of scoliosis. Is scoliosis something that can be completely fixed and treated at a low angle? Or is it something that we're trying more to manage to prevent from worsening?
So scoliosis is, the stages are mild, moderate, and severe. So mild is 0 to 25 degrees. Now when we see kids, 9, 10, 11, 12, and they have a smaller than 25 degree curve, some of those kids actually get to the point where they no longer have a scoliosis. Moderate curves are 25 to 40 degree curves, and those get more difficult. So our goal is really to reduce the curve down, but the person probably will still have scoliosis. Okay. Then we have severe curves, which are 40 degrees and higher, and our goal there is really to make sure the curve is not progressing. If it is progressing to a very severe curve, we're going to consider surgery, and our goal is to reduce it to a point below surgery. So if a patient comes in with a 50-degree curve, our goal may be to get it to 35 degrees and stabilize it so they're below the 40-degree threshold of surgery.
Okay. Is there a different approach to treating somebody with a high degree curve in more extreme cases? Then
So
compared to
the higher the curve, the treatment is going to look similar, but the patient's going to have to do more things at home. So we use something called the scoliosis traction chair and also something called the Scoli brace. So the larger the curve is, we may recommend that they have those things at home where they're also bracing
Mhm.
and they also have the scoliosis traction and chair at home. But the 2-hour visit is going to look similar. What changes is the frequency they're coming in, how much they're doing at home, is the brace required.
Okay. In terms of bracing, so why don't we brace, for example, kids who have mild scoliosis? Why do we only focus on bracing on more extreme
So
cases?
initially, bracing, if a curve was above 25 degrees, is when they're doing bracing.
Mhm.
But now you bring up a good point. Some of the clear doctors are bracing kids with 15, 20 degree curves now. But the standard is really, in the medical community, 0 to 25 is watch and wait.
Mhm.
So we were offering something progressive even without bracing. Our Mix, Fix, and Set program is a very proactive program that gets results without bracing 0 to 25 degrees. 25 to 40 degrees traditionally is when the medical community would do bracing, okay? So when we started doing bracing, that tended to be the time when we would also brace and use what we call the Scoli brace. It's a new type of 3-dimensional brace. We feel like it's the best brace out there right now. So in the 25 to 40 degree cases, sometimes we'll incorporate the bracing. And then 40 and above, we find that the bracing gets better results because the lever arms of your muscles change when your curve gets that large.
Mhm.
So most exercise makes this curve worse, and the brace helps to overcome that along with the scoliosis traction chair.
Okay, so you're saying somebody who has scoliosis and does, let's say, weightlifting and sports and everything, will be at greater risk to increase their curve, or
So some sports you're definitely more prone to make scoliosis worse. Rhythmic gymnastics, anything that causes hyperextension. So rhythmic gymnastics, ballet, volleyball, and competitive swimming have been shown to be a risk factor. So they took people that already had scoliosis, then they looked at what sports they were doing, these are in kids, and then they looked at whose scoliosis grew and got worse. And the kids doing those sports, it got worse. Now, we don't recommend weightlifting because when you look at a patient that has scoliosis, the worse the scoliosis is, as they strain, you'll see they actually go into their curve. So like if you see somebody doing a pull-up, they'll go into the curve. If you see somebody doing a sit-up, you'll actually see the umbilical, the belly button shift over to the direction of the curve. So extreme exercise tends to make curves worse. So in the beginning, we want them to really focus on our exercises. As we improve the curve as much as we can and stabilize it, then they can slowly get back to other exercises.
okay. Multiple people have always told me throughout my life that swimming was a good thing for scoliosis, but from what I understand, it's not necessarily actually helping.
Yeah. So you have to remember a lot of things are anecdotal, right? So let's say a GP or a chiropractor has a patient, they have a mild scoliosis, and they're at like a pre-puberty age, which when a kid's younger, the curve tends to get worse or it may self-resolve. I'm talking like 5 years old to 9 years old, let's say, okay? So let's say a kid gets diagnosed with early scoliosis, joins the swim team, and the scoliosis goes away. So the chiropractor and the medical doctor think, okay, I have a case here, it seems like swimming helped, right? But when we looked at scoliosis patients, they did a large study in Australia, and they found that people that do competitive swimming, we're talking about like where you're aggressively swimming for like 2 hours, it's swim practice, that if you already had a scoliosis, like a 20-degree curve, your risk of it developing to a 30, 40 degree curve increased if you were a competitive swimmer. So we, let everybody know that that is a risk factor now because of that study.
Okay. So somebody at home who may think they have scoliosis, who's maybe experiencing symptoms, what is their should they come in to visit for a visit to get checked, or is there something at home that they can do to maybe screen for scoliosis? What should the next step be if you...
On our website, drjhartley.com, we have a app on there that helps you to diagnose scoliosis. So you're looking at shoulder asymmetry, hip asymmetry. When the person bends forward, do you see a rib arch? But the earliest you have any inclination that there's a problem, you should come in and get an exam, because a proper exam with an x-ray tells us more than anything. So it's the standard school scoliosis screening. When you read the literature, they actually call that the too late test, because by the time you show up with a rib arch, then the scoliosis has already progressed. So it's much better to take care of these things, before they get to that point.
Okay, so it's something that even if somebody's not experiencing any pain, it's something that they want to get checked and maybe treated.
So if you see anything at all as far as a hip looking unlevel, you think you're seeing something with your child's ribs if they're bending forward, any kind of arch, shoulder unleveling, they should come in and get an exam and potentially an x-ray, because that's the only true way to monitor. And these curves are much better handled when they're smaller and the child is pre-puberty.
Okay. So I want to talk a little bit about scoliosis development. Is there a period of time where the worsening of the curve or the curve progresses at a faster rate? Is there a time when correction can be made more easily? For example, maybe in adolescence?
Sure. So during puberty is when the curve tends to accelerate. So small curves tend to become large curves. So if you already have a curve pre-puberty, you're at very high risk to have a large curve, and it usually accelerates during puberty. Girls usually earlier than boys. So when girls are 10 to 12, boys 12 to 14, these curves can accelerate dramatically. And so you may just be going to the pediatrician for a checkup and be 10 years old, and they go, I see a slight curve there, we're just going to watch it. You come back when you're 11 or 12, you may have a 30 or 40 degree curve. Progressive scoliosis during that time period can progress as much as 10 degrees per month. So you can go from having a 10 degree curve, and 4 months later you could have a 40 degree curve.
In terms of scoliosis surgery, when the scoliosis gets to a certain point, a lot of, medical doctors recommend getting surgery. So what are your thoughts on the effects that it has, maybe long term? Is it something that can actually help, or is it something that may damage even more?
So if it's a true progressive scoliosis, we will have patients, in the last couple of years, we've had a patient that had a 90 degree curve that we sent to the Philadelphia Children's Hospital for a tethering surgery. But if the curve is close to 40 degrees, then the patient really has options as far as how do they want to treat it. So if the child's motivated not to get surgery, then they're a good candidate for our program, because they're going to want to do the exercises to avoid surgery. Once you have surgery, you cannot reverse the surgery.
Right.
So when you look at the literature, the hardware for the surgery will eventually fail. The question is just, will the patient live long enough? We've had patients get into car accidents and the hardware will break, okay? And then the surgeons don't want to go in there and take the hardware out. It's a much more complicated procedure. We had a patient that they decided to take the hardware out when they were 25 because they started to have some failure in the hardware. The screws were backing out, they had some screws break, and when they took the hardware out, it affected the cerebral spinal fluid, and they developed severe migraines. And we were able to help them to get out of that migraine state that they had for several years after the surgery. So there are risks. Obviously you're going to have less mobility. You are going to, in most cases, have a scar. And you still are going to have some cosmetic issues, meaning, like if you have a rib arch and you have a scoliosis, you're still going to have some rib arch. It's not like cosmetically everything's 100%. So we talk the patient through the risk, the options. Some people would rather have surgery than be doing exercises for the rest of their life. So it is something we talk to each patient about very seriously and go through their options.
Okay. Something you just said about doing the exercises for the rest of the patient's lives, is that something that every patient needs to do to maintain their scoliosis, or what are the effects of doing the exercises and going through the treatment and then stopping?
So all small curves will progress to larger curves. It's just a matter of time. So you go through a progressive period during puberty, then after puberty through young adulthood, every year or two, the curve will increase a year. So if you have a 20-degree curve when you're 20, then when you're 40, that's going to be a 30-degree curve. So it's very important to keep up with your alignment and your exercises. We just think about it like brushing your teeth. These are, it's just maintaining your health. But if you have a 20 or 30-degree curve and you just ignore it, then when you're 60 years old, you're going to have a 40 or 50-degree curve. So we teach you exercises to help to maintain these curves, to control and prevent progression, not just during puberty, but in adulthood. And you'll be healthier for it later on.
Okay. When a patient comes into the clinic for a visit, what are maybe some of the tests and assessments that you do before starting treatment, in terms of maybe x-rays and tests to determine the severity of the scoliosis?
Right, so there's two different types of patients. One, the patient may think they have scoliosis, but they might not. So we do an exam, we're looking at their posture, we're doing neurological and orthopedic tests. We do the Adams test, which is where you bend forward and look at the rib arch. That's on the app on our website. You can look at that. And then we use the scoliometer, which is something we'll roll on the spine and it'll give us an idea of the curve. If we feel like it's indicated, then we do x-rays. The more severe the curve, the more x-rays we do. So if we know it's a severe curve, we're going to also do bending x-rays to look at the flexibility, to give us an idea of how much correction can be made. If it's just a screening and we're doing the PDA scoliosis x-ray, we're just trying to find out, does this person really have a scoliosis or not, and how big it is. So those might be the 0 to 25-degree patients. And then the 25 to, let's say, 60-degree patients, we're going to probably also be doing these bending x-rays to look at their flexibility, to determine how much we think the curve can be reduced.
In terms of reduction, does that have to do maybe with also the type of scoliosis? Because researching online, you can find a lot of stuff about idiopathic and structural scoliosis. So what exactly is the difference between the two, if there is any?
So idiopathic, the word idiopathic just means that we don't know where it came from. So most childhood scoliosis is going to be described as idiopathic scoliosis, okay? If we see some kind of wedged vertebra or something like that, or it's from an anatomical short leg, then that's going to be more of a hard bone problem that's not going to be able to correct it. We do something in the office called stress x-rays and bending x-rays, so that lets us see, is this a correctable scoliosis. So when we do an x-ray with spinal weighting or in the scoliosis chair, just their bending x-rays, it tells us, is this a scoliosis that can be corrected back to normal or improved, let's say.
Okay. Working in the office for the past year, I've kind of noticed you talk about the loss of the lumbar and cervical curves in scoliosis patients. Is that something that is causing the scoliosis, or why do patients experience that loss of the curve, and how do we try to kind of restore them?
Yeah. So when we look at a normal spine, you have a forward cervical curve, backward kyphosis curve, and a forward lumbar curve. That gives us our body strength and flexibility. Once the scoliosis starts and our spine shifts to the side, if we also have a loss of those curves, as gravity comes down, it makes those curves worse. So there's studies that have shown that if you can improve the thoracic kyphosis in a scoliosis patient, you're going to reduce the curve down. So we're always working on the scoliosis three-dimensionally. We want to have that forward lumbar curve, forward cervical curve, backward thoracic curve. So we're working with the curve three-dimensionally, and that's one of the big differences in our office. And let's say if you just go to a children's hospital and you're going the medical route with how you're working with scoliosis, they're just looking at a front view x-ray, and then they're going to put you in a brace or decide to do surgery just on that front view x-ray. We're also looking at the spine from the side view. We're looking at bending x-rays. We're looking at other factors to determine how best we think the scoliosis should be treated. And most patients that come in, feel like the exam we give them is the most complete and concise exam that they've ever had, even if they've been to some pretty prominent children's hospitals around the country.
Okay, perfect. Well, thank you everybody for watching. This is going to be the end of the first blog with Dr. J. We're going to be making more videos soon, covering more topics. So if you'd like to see more of those, subscribe to the channel. Dr. J, what is the channel exactly?
The channel is Hartley Chiropractic and Scoliosis Center on YouTube, and then the website is drjhartley.com.